Hello everyone and welcome back to Medi Notes or Medicos after a long break. I'm extremely sorry for the delay for the videos. I was having my university exams and was engrossed with the studies. But without any further ado, let's get back into the video. So the topic we're going to deal today is about megaloblastic anemia from pathology. And we're going to deal with the introduction, the cause, etiopathogenesis of both vitamin B12 and folic acid deficiency, the pathogenesis, the clinical features, the lab diagnosis. Now, what is megaloblastic anemia? How can we understand that a particular anemia that a patient brought in the OPD has? It is basically characterized by two different ways in pathological form if we go. One is by the distinct megaloblasts in the bone marrow, and second is by the damaged or impaired DNA synthesis. So there are two ways by which we can characterize a megaloblastic anemia. So the most prominent causes of megaloblastic anemia, it would either be vitamin B12 deficiency or it would be folic acid synthesis. It can sometimes be both the deficiency together. So when we look into the etiopathogenesis of vitamin B12 deficiency, it can be caused because of decreased intake. Now when we say a decreased intake means what? In vegetarian people, when we see the sources of vitamin B12, it is most prominent in red meat. So vegetarians would not consume meat, as we all know that would cause a decrease in the intake of vitamin B12 in their diet. Then we have an increased demand in certain cases like pregnancy, hypothyroidism. We face an increased demand of vitamin B12. Next is decreased absorption. So there are two types of cases in which we can see decreased absorption. One would be the gastric cause, and the second would be the intestinal cause. When we go to the gastric cause, it is caused because of a decreased gastric acid, peptone, and intrinsic factor. This can be seen in cases like malabsorption post-gastrectomy. When we go for the intestinal cause, we see a decreased surface absorption area. So this is the etiopathogenesis of the vitamin B12 deficiency. When we go to the etiopathogenesis of folic acid deficiency, we see that there is a decreased intake. In cases like malabsorption syndromes, there is an increased demand in cases like pregnancy. This is the main reason we prescribe for the pregnant women folic acid 3 months prior to the conception and throughout the pregnancy. Next, we go through the increased hemodilation. We can see increased hemodilation in case of pregnancy. Decreased absorption, again we already dealt the decreased absorption in case of etiopathogenesis of the vitamin B12 also, that is decreased gastric acid, peptone, and intrinsic factor is one reason of it, and the other is the decreased surface absorption area. The next is small intestine diseases, lymphoma, etc. Then we have increased erythropoiesis. What is the pathogenesis? The first one, I told that the characteristics of megaloblastic anemia is either it would be having distinct megaloblasts in the bone marrow and it would be having a damaged or impaired DNA synthesis. There are two characteristics. Now when we deal with the pathogenesis, it would be having an impaired DNA synthesis. In this, what happens is the nuclear development, it gets delayed. This causes megaloblast formation. This causes the formation of macrocytes. So that is how the DNA gets impaired, and then we have increased hemopoiesis. Now we will look into the clinical diagnosis. So what are the features that a vitamin B12 deficiency or a megaloblastic anemia patient would be showing you? This is a characteristic feature. This is the beefy swollen tongues, that is softness, red and painful. This is the characteristic feature of a vitamin B12 deficiency. If a patient comes and reports to you with beefy swollen tongue along with clamping of hands and legs, clamping of hands and legs can also be presented as paresthesia, along with muscular weakness and body pain, pale skin, lips and hands, this would definitely be a case of vitamin B12 deficiency under megaloblastic anemia, and you can clear go for a clear cut diagnosis that it is actually a vitamin B12 deficiency anemia. So this is how a characteristic red beefy tongue would be looking like. If you look into the screen properly, you can see this tongue. It looks like a beefy tongue. Beefy tongue is because if you see a red meat, that is, I don't know if you have seen a red beef, but if you have gone to your microbiology laboratory, there is this biphasic media in which you would be seeing beef type substance, because in the medium we would be using beef. So this is a beefy, it would be looking just like this. So that's why when we gave the name, it was given as beefy swollen tongue. It would have a bit of swelling, unlike being a plain one. And then we'll be having a shortness of breath. The patient would be fatigue is a basic characteristic of an anemic patient. Then we would be having the clamping of hands and legs. We would be having loss of appetite. The patient would be showing muscular weakness, body pain, pale skin, lips and hands, and also sometimes cases of diarrhea. Now we'll be going into the lab diagnosis. So the first lab diagnosis we would be doing, because it is pathology, is a peripheral smear. Even if we are going to diagnose in the clinic side also, we would be going for the lab diagnosis. First lab diagnosis, we need to go for a blood test, and the blood test would the pathologist would take a blood peripheral smear from that blood, and in there we would be seeing hemoglobin and the hematocrit would get decreased. We would see an decrease in MCV and MCH. We would have normal MCHC values, but we can see pancytopenia over here, and you can see hypersegmented neutrophils. If you look into the picture properly, you can see hypersegmented neutrophils. You can see macropolyps or teardrop cells, and macroovelocytes. You can see macroovelocytes and macropolyps. Next is bone marrow findings. So usually in a normal this picture over here, you can see presence of megaloblasts, and also you can see giant metamyelocytes. So this one over here is the presence of megaloblasts, and this over here is giant metamyelocytes. These all are giant metamyelocytes. Now we would be having the specific tests for vitamin B12, that is we would go for vitamin B12 serum test. In that we would be seeing that the vitamin B12 obviously it would have a decrease. Then we have a special test for vitamin B12, that is known as serum methylmalonic acid. In that the serum methylmalonic acid would show an increase. When you go for a urine test, it would be showing that the urine excretes methylmalonic acid, and that urine excretes methylmalonic acid, the methylmalonic acid would have an increase. When you go for specific test for folic acid, you would be seeing that we have two tests. One is serum folic acid test, and other is the Figlu serum. In that you go for the serum folic test, you would see a decrease in the serum folic acid, and if you go for the Figlu serum, you would be seeing a decrease in it. Now we would be going for the lab biochemical test. In that we would go for plasma lactate dehydrogenase, that is LDH test. It would be increased. Serum homocysteine would increase. Serum bilirubin would increase. Serum iron and ferritin would increase. Serum vitamin B12 would have a decrease. So that was the video for today. I hope you like this video. If you like this video, don't forget to like, subscribe to our channel, and also share it. We'll be coming with more educational videos. Till then, stay tuned. This is Ashna Viraja signing off for today. Bye.